So, ladies and gentlemen, doctors, pharmacists, and all healthcare professionals, KMA members, and non-KMA members, allow me to welcome you to today's webinar. Our speaker today will be Dr. Justa Simba. My name is Dr. Stephen Uche, the KMA Thika Division Chairperson. We'll start the webinar in the next 2 minutes. I'm just waiting for a few more people to join so that we start the webinar. So once again, welcome to today's online CME stroke webinar. For those who have just joined, my name is Dr. Steven. So this webinar will take approximately 1.5 hours. If there are any additional comments or should we extend, we don't expect the webinar to go beyond 2 hours. So just to take you through the program, we'll have a presentation, an online a virtual presentation from Dr. Justus Simba. We'll then proceed to having a Q&A session, which will take about 10 to 20 minutes. And then we'll have a short presentation, about 5 to 10 minutes from Krishna Pharmaceutical Limited. So our presenter today is Dr. Justus Simba. Dr. Justus Simba is a consultant respiratory pediatrician who attained his MBCHB degree and undertook an MEd pediatric program, training at Moi University in Eldoret. He has undergone clinical training fellowship in respiratory medicine through European Respiratory Society at Alder Hey Children's Hospital in Liverpool, United Kingdom. In 2021, he completed his PhD at the Jomo Kenyatta University of Agriculture and Technology, JKUAT, Kenya. Earlier this year, he was awarded Foundation Fellow status of the East, Central, and Southern Africa College of Pediatrics and Child Health. As an academician, he has participated in undergraduate and postgraduate training, and currently he is a senior lecturer at the Department of Child Health and Pediatrics, School of Medicine, JKUAT. As a clinician, he is currently attached to Mama Lucy Kibaki Hospital, Nairobi. He undertakes his private practice in several facilities within the wider Nairobi metropolis. He has special interest in evidence-based medicine, more so in pediatric respiratory medicine, as well as in advancing child health in the country. He has served as a peer reviewer in several international journals. He currently serves as an associate editor of the Pediatric Pulmonology Journal. Besides that, he's the vice chairperson of Kenya Pediatric Association. He is an active member of the Respiratory Society of Kenya, Pan-African Thoracic Society, as well as the European Respiratory Society. He is also an author and a publisher. He is a co-author of the Victoria Pediatric Casebook, an academic textbook that is used in the teaching of medical students in various universities. So allow me to take this opportunity to welcome Dr. Justa Simba to take us through the management of asthma in children. Welcome, Dr.
Thank you so much, Daktari, for the kind remarks. I will share my slides and then proceed to uh, share about asthma. This happens to be the week where we were celebrating where we're celebrating asthma. And so I will be um, going through this pediatric asthma, and hopefully at the end of the day we'll have a discussion and I'll have clarified some of the things that you may have questions or about. So basically this is part of where I do my work, and we have the Kenyan Asthma Management Guideline, which is part of the things I will say are related to this, and this is a guideline which I was lucky to be part of the team that pushed together what is in that current guideline. And we know this week on Tuesday, we had the World Asthma Day, and the Global Strategy for Asthma Management was released, and it has some updates on some of the aspects, and I'll touch on some of those things in this presentation. So I started by showing those guidelines, and basically, we generally usually feel that if you have guidelines, you are likely to end up with a situation where uh, you will be you you usually hope that these will be able to maybe change the care and of the patients you are seeing. And we did write an editorial, and this editorial basically said the provision of guidelines is a tool that will help us reduce the which will help us reduce the gap in asthma care, and hopefully we advocating for availability of appropriate inhalers and spacer device plus their inclusion in the national medication formula. And when I come to the theme of this year's that asthma day, I'll reflect on this a bit more. So just to make us be in the same space, a 3-year-old presents with recurrent coughing and wheezing. You notice she has features of both allergic rhinitis and conjunctivitis. And as we reflect on that, we basically would want to, as we go along, we want to ask ourselves, what should we consider in the diagnosis in this particular child? And what are the risk factors for development of this condition? And so the first thing we usually want to start us off is to ask ourselves, why should we discuss asthma? And asthma is actually the most common chronic disease in childhood. And I know that statement people probably don't interact so much with asthma would feel it's out of place, but actually it's the reality that asthma is the most common chronic disease in childhood. But there are issues whether it receives the attention that it requires. And in many low and middle income countries, the incidence is increasing, and about 250,000 children die annually from asthma in low and middle income countries. That the total number is around 450 individuals, including adults, die from asthma worldwide. And that number is actually closer to what the deaths of malaria are. So malaria for quite some time in the just before the interruption by COVID had actually fallen below 500,000. So you can see it's really a condition that kills people, but the attention is not as much. There's a lot of underdiagnosis and undertreatment of asthma that contributes to these deaths. And there is the asthma care as high cost that is worsened by limited availability and access to medication. No wonder the theme around the asthma care this year is actually around these inhaled medications. And so basically, when you go to the definition, this definition has not been updated. It remains the same, and actually word for word for a couple of years now, Gina has reproduced it. And one of the things I want us to carry along during this presentation is the fact that asthma is an heterogeneous disease. It's actually not the same disease. So there's no individual probably who has the same characteristic as the next patient you will see. They so that brings us a bit of issues around how we care for patients and how we manage them. But to underline one of the key concepts around asthma is that it's actually a chronic airway inflammation. So you can't just say asthma is an allergy. So it's a chronic airway inflammation that we know is defined by the recurrence of the symptoms of wheeze, shortness of breath, chest tightness, and cough. And I probably just need to underline that cough is actually the commonest among those. And this tends to vary over time and in intensity, and there's variable expiratory airflow limitation. The other thing is that, as I've already mentioned, that heterogeneity therefore leads to the concept of that you have recognizable clusters that are referred to as asthma phenotypes that are characterized by different demographics, different clinical presentation, and the pathophysiological characteristics. So does every child under 5 who is recurrently have asthma? So this is one of the key things that I know this quite disturbs, and usually most of the time people do not have a clear answer. But for the first time, Gene actually has provided a clear roadmap this year that it just tries to now say this is a diagnostic criteria for asthma in children who are aged 5 years and below. So you notice uh, children who are 60 and above, a lot of things for them actually tend to, in terms of diagnosis, will work towards what is done in adult, except a few challenges maybe that may occur. But the first thing is that you want to ascertain that someone has recurrent acute wheezing episodes. They will get these wheezing episodes that come, and either when they are treated, they will stop, and such related characteristics. And this is where medicine comes into play, that we want to evaluate this child. We want to think through the history, physical assessment, to be clear that there is no likely alternative cause for the respiratory symptoms. The fact that someone is wheezing, a baby is wheezing, to be honest, it could be that they are having heart failure, and I've actually seen patients who have heart failure or have been started on an asthma medication or even anti-TB or other things, and they're actually in heart failure. So this is an important thing. That patient who appears wasted, for example, before you say they are wheezing because of asthma, we need to tease out, could there be another condition? Because that other condition is more likely. So those are the reasons as to why evaluations have to be done. And evaluation does not necessarily mean imaging or testing, but the proper taking of that history and physical assessment. So that the other thing, the third criteria which has been put, and the patient must meet this criteria for these children for you to ascertain that this is a diagnosis of asthma. And if they don't meet the three, then there will be suspected asthma or probable asthma. So the last one is the timely clinical response of respiratory symptoms or signs to asthma medication. And this is important, that patients who appear to, when you give them short-acting beta agonist, I actually had a patient in one of the hospitals this week. They were actually admitted on Monday afternoon, very severe distress, nebulized. By the time it was Tuesday, they had actually responded so well that by Wednesday they went home. These are 7-month-old baby. You start thinking, are their airways really sensitive to this? They are responding so much to this. So you look out for other possibilities for that particular patient being a 7-month, but then you have to be aware this is likely to be initial presentation or asthma. And so the other things is the reduced frequency or severity of acute wheezing episodes and or symptom between episodes during when you do a trial of therapy. So trial of therapy using the innate corticosteroid is actually a key concept that is not a fault to tell a patient that we are actually going to do trial of treatment for you at this particular point. What about the prevalence of asthma? So the prevalence of asthma basically in Kenya is estimated to be about 7.5, or another text will make it 10, will talk of 10%, but just important to appreciate that about 4 million Kenyans have asthma. So if you have 10 people in a line somewhere, we're almost sure one person has asthma, whether they accept it or not. And I'll come to that concept of whether they have themselves accepted they have asthma. And we know that asthma is more likely to appear in the urban rather than the rural areas. And there are a few things, and I'll come to a slide that talks to that. And we also want to appreciate that there is actually no population-based studies in asthma, except some of the studies that were done in Eldoret and in Nairobi. These have been there for quite a bit of time, which looked at the prevalence of asthma in those contexts. So just to refresh our minds that risk factors for asthma development, and this is asthma development, include genetic factors. That's why you want to ask about, are there family members who have these, their other children, and people in our sector tend to deny. So you have to figure out how to ask that question, including what drugs do people use, and just asking them, maybe if I was to use a Kiswahili word, kama kuna mtu ufungana, that means is there anybody who has their chest congest in your family. But sometimes just saying, is there asthma in your family, you are more likely to get that it will not be accepted. And we have data which you have published to show that it's only 30% of people in our setup who will accept diagnosis of asthma from on the word go. And then you have the environmental factor, and this is a key and important factor. Mold. I have patients who the only thing they have had to change for us to reduce the frequency of treatments is actually handling the mold and such like related things within their set. And then the infectious agents. The infectious agents, one of the key things is, and I think demonstration in this particular slide is basically the viral infection. RSV is notorious for this, and human rhinovirus. These are part of the things that will give you trouble. So that patients who has RSV in their first year of life, and now we know things have advanced, we are able to actually confirm what viral infections are you having. And so these are patients we know they might give us trouble later on. And asthma has the concept of possibility of probably just saying that is good. So people who have stayed in the farm, and this is on, are likely to be better off as compared to those who have stayed in urban areas, who have been exposed to smoke, pollution, excess early weight gain. Yeah, that predisposes people to having airway issues, airway inflammation, and therefore they end up with asthma, and then prematurity in itself. And pathological or abnormal gut microbiome. So these are things which predispose someone to having asthma, and some of the things that we just need to keep in mind even as we see these patients or think about the future for the people we see. And this, I promise, is the last one for those who probably usually do not want to go into these details of medicine. But basically, just to summarize, what is happening at the airway? There's a cartoon on this right side screen, shows the normal airway. And I like having models. In some of the clinics I run, actually have models of this, and to show patients where are we moving from. We are moving from this normal to asthmatic airway. The not so good news is that if you have wheezed after 5 years, then your airway is not ever going to be very normal. To always have that wall inflammation, it's a bit thickened. And now when there is acute asthma exacerbation, then you have worse uh, inflammation, and there is tightening of the smooth muscle. You can see it somewhere there, and that makes the air be trapped in the alveoli. So these are things we need to think about, and this inflammation, which I've highlighted there, is the basis for why asthma, when it's being treated, you have to have corticosteroid, and it's safer to use the inert corticosteroid. And I like saying, for example, if you're going to treat a patient with diabetes and is a child, because they are likely to have type 1 diabetes, you don't give them insulin, you keep being in circles, and you're going to keep just maybe either giving fluids and other things, and you're not going to go anywhere. So you have to think about asthma as a chronic inflammatory airway condition. And so you have to safely give steroids. And so the safer way to give steroids is actually to give inert corticosteroid. It's a very low dose, and it's in micrograms. Now, I probably alluded to this. So the World Asthma Day was on May 6th, which is just this week. And the theme was make inhaled treatment accessible for all. And this is inhaled treatment. which can be the inhalers, the nebulizations, and all that. So please notice that not syrups and all that being mentioned here. But we have looked at some things which are likely to impair your goal. You want to achieve control in these patients who have asthma, but what are some of the pitfalls around that? So parental perceptions on asthma in Kenya is a big thing, and we did some work both in Eldoret and some work replicated that in Mama Lucy and showed that people really have perceptions. And when I see a new patient, they come to us with the feeling that I'm going to be told I don't have asthma. And when they start talking, you can figure out this is asthma. So you have to walk from someone who came to you to tell them you are to answer their prayer, which they had prayed that you probably are going to tell them they don't have. And then you can see it's the one. And then you have to walk them all the way until they accept that their airways have some issue. And then subsequently, depending on how they appear to react, subsequently we can put names into what that condition is. And I found that strategy to work. And I've mentioned earlier the availability and adoption and utilization of available guidelines. The sad reality is that these guidelines, I showed that guideline, the Kenyan guideline on the first page. The sad reality is that guideline has not been adopted. One of my postgraduate just finished his actually exams yesterday. I looked at how people were actually adhering to that airline, and the performance was dismal in among the healthcare workers who are seeing people who had acute asthma exacerbation. Then we have the inequalities in respiratory health, and we have done some work to published work to just try to describe what are these inequalities and what do they really bring. We know people are not in the same spectrum, and I'm sure within the audience here, people work in high-end private hospitals, the other people are in the really low settings within our setup, and that has differences in what exactly we do. So I think I've mentioned this work for those who might have interest, knowledge, and perception of childhood asthma among caretakers of children with asthma at a national referral hospital. It really gives you a bit of detail. The abstract in this work summarizes patients exactly what they come saying. They don't want these drugs. They think these drugs are for the very sick children or the very sick ones. They think they have not yet reached there. They would prefer syrups. I've not prescribed syrups for 5 years, and I personally strongly believe it is important we promote safer drugs, especially because of the quantities of drug that will go into the bodies. And I mentioned this editorial that we had written even previously about the implication. I showed you the conclusion really around the availability of this guideline, the availability of the inhalers, and awfully. And then this work which we did in one of the European monograph to just describe preventable deaths from respiratory disease in children in low and middle income countries. And it's done with colleagues in this country, both respiratory pediatricians and also mentees and other people we work with to describe those concepts. So I move on to another case. A 10-year-old present to the pediatric respiratory clinic at Mama Lucy Kibaki with history of cough, recurrent wheezing. Over the last 1 month, he has had 2 mild flare-ups. He was discharged from the wards 2 weeks ago for an acute episode. The mother wants to know what next. So a lot of maybe quite a bit of things wrapped in here. One of it is the word flare-ups, and maybe I spend 1 or 2 seconds around that. So every time I look for at the page, when the gene updates the guideline like they did, I try to check what are they discussing about nomenclature. So the nomenclature of asthma is quite interesting. Do you want to say exacerbations? Do you want to say attack? Do you want to say flare-ups? And episodes and all that. So those are some of the things those who are interested. But flare-ups is thought to be an easier or a milder term to the people, and they are likely to pick it. So this particular patient, the aim here is to ask ourselves, how frequent is this asthma? So then we are able to ask ourselves, what is the goal of treatment? And this is basically the GINA 2025, just showing a bit of what that particular patient is likely to end up with. So you're likely to end up that patient putting them on a daily low dose innate corticosteroid. And this step 1 to step 5, one of the things we have to notice is a patient can actually walk, swing back, especially between step 1 and step 3. Most of the patients who come to us, we tend to start them at step 2 and then try to swing them depending on their response, either to step 1 or step 3. But one of the things I want us to notice is that GINA no longer accepts that when you put someone 6 years and above on treatment for what you perceive to be asthma, that they should be on short-acting beta agonist alone. So that's no longer accepted as proper care. So that patient, it's okay depending on where their situation to even put them on short. So there are bouts of using the ACS, the inert corticosteroid plus salbutamol, which is common in our setup, the short-acting beta agonist, and then they can stop, especially if they stay for so long without having other flare-ups in between. The other concept which is highlighted here is the concept of maintenance and reliever therapy. And if you look at the reliever down there, you notice that it is possible for patients to actually be on an ICS for metro reliever. Please notice it is ICS for metro. You can't use ICS salmeterol as a reliever because they are both long-acting beta agonist, but for metro has a short onset of action. Within 6 minutes, it will have started acting, and therefore it's possible to give the patient what they want to feel that the chest has opened. And so many other things which are highlighted here, including what can be add on to those particular patients. What we want to hope is that the patient is not going to be on step 4, step 5, and these are patients you are better off having them being seen by the specialist just to make sure that we are teasing out what other things can be. But a lot of patients who are at step 1, 2, and 3 can be managed by most colleagues, as it was. So one of the things which is up there is the personalized asthma management, the assess, adjust, review. Whenever it is possible, when you assess, think of that alternate diagnosis. How is the inhaler technique if this patient is on inhalers? One of the single most common problem why people are not improving is because they're actually using the inhaler wrongly. So in children, we prefer that children will use inhalers with spacers. And the difference is the 6-year-olds and above can use with a mouthpiece, but the younger ones needs to have the face mask on that spacer. I've actually had a patient last year, September, who actually had used the inhaler for 2 weeks without ever having pressed it. And the mother, not an average mother, she seemed well educated for maybe to describe her. And she was convinced that she was told if you just place the inhaler at the end of the spacer, it will actually come out. Of course, there are inhalers that you don't need to press and the act of breathing, but those ones are not used with spacers. And so there was a bit of issues. Where did that information, is it that he just understood the information the other way around? And that's why it's important that patient you see every so often, like 3 months, it's important to ask them to come with these devices. And you actually notice, some of you have watched they call Dr. House. Yeah, I was there, and you have seen how that lady there would use the inhaler. They just press on the neck because when the person demonstrated, they didn't probably use the inhaler directly because they tear drug and they didn't want to use the drug, and so the patient thought we just need to spray it around the neck. So please check that. Discuss with people what is their preference. There are many types of these devices, and what would they want to use. And then when you adjust, you want to think of non-pharmacological strategies. Sometimes, and my mentor in the UK, Steve quoted the facility I happen to have been in, uses more of the non-pharmacological strategies, the clinical psychologists, the clinical nutritionists, the clinical other people, just to talk to those people. And they have actually, while they are able to do a lot of biologicals in their setup, they actually reduce the use of biologicals, which will be the latter step 5 here, by just talking to people. Sometimes other things come in and then they make our symptoms worse. And one of the things maybe I'll point out on this other side is, of course, you have to think of the side effects, comorbidities, allergic rhinitis in our setup, gastroesophageal reflux disease. Food allergy is still a possibility. So you have to think about it. And whenever it's feasible, please do a lung function. In fact, Gina, even when they write that page of resource poor setting, they still insist as much as possible, let's do lung function whenever it is possible. Because sometimes people have just been treated for asthma and they actually have totally different issues. I wanted to highlight just something small on this on the 5 years and below. And this particular part is just to show that there's the maintenance, the ICS for metro that we saw in the other slide is actually not in this young than 5 years. I know there are some patients who are not, who are no treatment, but please remember, generally you are using it off label. I think the ATS, the American Thoracic Society, allows the ICS for metal and basically the ICS labas, the ICS net corticosteroid, the long-acting beta agonist to be used from 4 years. And so generally when you're putting that baby who is 1 year on ICS laba, that's truly off label. And so unless there's compelling reasons, their safety have not really been evaluated in this particular age group. And sometimes they are actually, I've had children who actually tell you side effects of some of these drugs, especially the ones who can talk for themselves. So just moving on again, the 17-year-old girl, so a 17-year-old girl comes, again, that particular child initially comes for a review 1 month after the initial consultation, and she is now happy and has a asthma control test score of 23/25. So some of these are scores you can use, but maybe to simplify some of the classification we would use is Gina puts this classification, which is a bit easier, and there are several components. So first component is just this particular part. By asking an individual these questions, how often do you have daytime symptoms? Do you have them more than twice a week? If yes or no. Have you had any nighttime awakening due to asthma? Have you required to use short-acting beta agonists for symptom relief more than twice in a week? And the asterisk there recognizes that now we have the MAT regimen, the maintenance and reliever therapy that uses ICS for metro or ICS and ASABA for some of the patients, especially the adults who would use that component, or more people are more than 12 years, and any activity limitation due to asthma. So depending on what you pick, then you are able to say either well controlled if none of them, partially controlled, or uncontrolled. And then the other assessment about asthma control is looking at the risk of recurrence, the risk of an exacerbation. People have had major admissions within the last 12 years the last 12 months at a higher risk of getting another exacerbation. And people have used more canisters of salbutamol, especially if they use more than 3 canisters in a year. So that's a red flag. If someone uses that, it's going beyond that, we need to make sure that we try and control the asthma much better. So this, I did a bit of a screenshot from the current guidelines, and I just wanted to highlight a few things. I know there is the issue of food and asthma, and sometimes you actually come across a child who has nutritional deficiency because they were told to stop everything, stop milk, stop what. So please, let's just agree. So in asthma, the airways are most likely responding to something. Sometimes it could be the tree outside your house, and you have no way maybe of confirming that. It could be the maze and anything else. It could be the mud and all that. So while it might be okay to, if you felt that it's a particular, maybe they are taking too much milk or something, well, it might be okay to maybe have a weekend or so, something, a short duration off, and then you try to recheck again. It is not recommended to tell people to just avoid all foods which are proteins, because that could be the issue. This is the current guidelines, and this information has actually been provided with the level of evidence for those of you who might want to look at better details. But where food allergies have been identified, then those patients can appropriately be taken care of and managed, and we try and sort that. Now, there is the other issue of avoidance of indoor allergens. So as a general strategy, and have one of my people who is very specific. I mean, they have done quite a bit of work in this allergy testing and allergies and everything. People actually agree that you you can't just telling someone throw away the carpet, throw away the cat, throw away the dog and everything. To be honest, probably doesn't help anyone. And that is why I probably highlighted this from the GINA guideline. Our allergy avoidance is not as a general strategy. You can't just tell everybody, don't do this, don't do that. However, there is the point of trying to look for house dust mites, pets. Some children will benefit from them, and notice that this is only limited to children. In fact, probably there is no change with that adults. And so some of these are the things we need to ask ourselves for this particular patient. What could really be their problem? And if we are able to identify that, then we can try avoidance of that particular thing. But just appreciate that telling someone to really avoid their body already has been made with the genetics and things that they are likely to over respond to general stimuli. So if you told them to avoid everything, then it's less likely to be for them to live a normal life. And so those are the things people have to appreciate. And but if you're able to get really the triggers specific to that person, then they can avoid that, but not a general blanket statement that you should just avoid everything that comes your way. Could have been up there in one of those things, but sometimes you wonder what if that thing was to snap. Now, so that's to look at asthma, and I probably felt maybe we could summarize a bit of the chronic, which is what I've done, and then finish it off with looking a bit of acute asthma care in what we are doing. And basically, an acute asthma exacerbation or flare-up, which I already mentioned, is a change in patient's usual status. Yeah, that they are known to, there are some people who wheeze actually every day because the asthma is that bad. So if it changes from that, then they're having an acute flare-up. Or someone who never wheezes and they have started wheezing or they're coughing more than they usually cough. So that's why there is that patient, or that concept of usual status. Remember, in children, this could be the initial presentation for that particular patient. Just to make us of the context in place, a 9-year-old girl presents to hospital with a history of wheezing that started 4 hours ago. She has not improved despite using a blue inhaler, 2 puffs at the onset. Except a few inhalers which confuse the color coding. Most of the inhalers actually are, the blue inhalers are likely to be the short-acting beta agonists, but I've said the 1 or 2 brands which have tried to confuse that concept. And so I try to talk to my patient in terms of what is the color of of your inhaler. Is it the pink? Is it the orange? Is it the brown? Is it, because that way people can remember colors, and if you are in that space a lot, you are likely to know if you are talking about maybe the pink inhaler, that's a budesonide, maybe the orange is a fluticasone, and that kind of thing, and it helps patients so they don't have to remember so many odd names. So this particular patient, I'm hoping by now you have reflected on this patient. We would actually say this patient has an acute asthma exacerbation or a flare-up. So what would be the immediate action? So immediate action, again, you have to remember the usual ways of doing things for patients who are in acute setup. So good to take a very brief history, focused history, that you, as you start assessing them, you're asking the progression, including the severity, any danger signs, including ability to talk. So ability to talk is a key thing. So these children, you just need to ask them, where do you go to school? And then if you feel they have answered in a monologue, maybe you extend it, what is your teacher's name? And as they try to tell you that, then you see whether they are pausing to breathe. I think we are now all familiar with the statement, I can't breathe, when someone decided to put their knee on someone's neck. And that's the thing that can help you to remember that actually when you are talking, you are not breathing. And so if you need to pause to breathe, you cannot complete that statement because it is probably too long for you, then there is a problem. Is there an possibility of an allergic reaction? Because that slightly changes what we need to do. And what drugs has the patient been on, including whether they are on any inhalers. We should focus on the general appearance for a patient as you look at their exam. How distressed is the patient, including ability to talk, use of accessory muscles. How are their vital signs, the respiratory rate? Remember, you could be breathing slow. You are not tachypnic, which is the commoner thing usually in asthma, that patients might just be having a prolonged expiratory phase, and therefore they just seem to be milking out air from their system. So you have to check how exactly are they breathing, how is the pattern, the heart rate, the temperature. SpO2 needs to be checked, and this is now a common thing. I think even now patients have SpO2 machines after the COVID pandemic. Blood pressure, whenever feasible, needs to be checked, and the likelihood of complication, the asymmetry of breath sounds, that also needs to be checked, because sometimes you have this child who has severe obstructive airway issue until they actually develop pneumothorax that can cause them trouble. Presence or absence of added sounds, wheezing, and the sounds actually keeps confusing. Now, Gene actually, I think they have decided to put it in brackets. So I know long time people used to say when you catheter wheeze is called a ronchi, but we know now that it's still a wheeze, but because the previously people would want to insist on it being a ronchi. Actually, the one for this year, actually, they have put in brackets ronchi where there is the wheeze. So whichever noise, and the important thing is their musical noise, a musical sound that you feel. A silent chest does not mean the patient is okay. In fact, if a mother tells you their child has ever been nebulized, and when you oscatate, you can't actually feel anything, and they appear to be in distress, to be honest, you can nebulize, and I've actually found those patients, when you now check again, you start feeling the wheezing, especially those patients who are in distress. Yeah, it's unlikely that you are having silent chest, you are in severe asthma exacerbation, and you are not having respiratory distress or other features of impending respiratory failure. Look for comorbidities. Obesity is key, and now we know we're struggling with this malnutrition spectrum, where we have children who have malnutrition, undernutrition, and then you have people who have obesity. And I know those are real things in our society. Eczema, allergic rhinitis. Check for that allergic rhinitis. Sometimes what you are treating as asthma is actually that this patient is also having postnasal drip that we are not sorting. And remember the concept of one-way hypothesis. So the upper airway influences what happens to the lower airway. So think about it. If something gets to your left eye, the right might cry. Something like that, for just those who want to something to remember. Examine for negative signs, a cardiac murmur. So if you find a patient who has a murmur, please, before you put them on an inhaler, it's good practice. Allow a cardiology colleague to evaluate this child and give you a clean bill that yes, the murmur could be there, but it's not. The heart is okay functionally, and so then at that point maybe you could think they are coexisting. But when you have figure clubbing, that's a sign of a chronic lung disease, less likely to be asthma unless you have already reached the fixed airways stage that is not going to happen maybe in the younger children. And then severe wasting, I already mentioned, that's not something you want to think about in asthma. In acute exacerbation, while we know international guidelines say let's do spirometry, we know in our setup it's probably not practical. And one of the pediatrician now, she did a work at MTRH and showed most of them will just cough around and probably not achieve much with that. So you can delay it, and that's what is in our national guideline. Blood gas should be done where it's feasible. Chest X-ray to be when a patient has severe exacerbation, it's good practice to do that chest X-ray, especially looking for other possibilities. But one of the cautions is that chest X-ray in acute exacerbation will have so much whiteouts because of the mucus. I've actually had to underline in my respiratory textbook, which is like the Bible of respiratory, that the part where that mucus in an X-ray will actually look white. And so those X-rays are likely to be reported. There's bilateral opacities, perihilar opacities, and they can be confusing. So you have to ask yourself, what was the aim of doing that X-ray? And in that time, you're actually looking for possible severe issues that could happen. And their typical presentation are the other things you want to look at. This is just a table that tries to, again, see how you classify these patients. Some classification will give you 3 classification of severe, moderate, and mild. but there's also the 4-class. This is what we adopted in our guideline: life-threatening, silent chest, poor respiratory effort, hypotension, bradycardia being a poor sign. The severe, unable to complete sentences, too breathless to talk, response to voice, has lower chest windowing, likely to be tachycardic and likely to have tachypnea. So this other one is when things are slowing down, we are not doing very well. Then the moderate one, differentiating it. So when you find a wheeze and the patient others looks okay, likely mild asthma exacerbation. You don't probably need to do so much at that particular point. But moderate and above, those ones are significant. We need to think about them, and there's a small difference in how you treat those patients. Nebulization, we still have to remember, is aerosol generating. I think this year, earlier we had a lot of influenza, and I know maybe we are moving them from one person to the other, including other patients, and we have to keep thinking about these aerosol generating procedures. I know we still have low COVID, but maybe it doesn't give a lot of issues as it used to give. Mild to moderate cases, you can actually use the inhalers themselves without necessarily nebulizing, and the severe, you can even have 6 to 10. When you need to use the steroids, have to be used from all patients who are moderate to severe. This is one thing which sometimes, to be honest, I'm asked to see a patient, and the only thing I do is to add just to add the steroid. And that inflammation, that diagram I showed earlier, just remember it. You have several options. You can either have your prednisolone, oral dexamethasone, but if you are going to use oral dexamethasone, 1 or 2 days max if it's oral. You can use IVs, steroids, especially those patients who are not able to sustain oral or are very sick. And preference is either to give IV dexamethasone, which is preferred, but also possibility of using IV hydrocortisone. I think this pictorial, we are well aware of it. In severe cases, again, then the nebulization comes in. We want to give our salbutamol 2.5 milligrams, less than 5 years. Patients who are probably less than 1 year dosage can be less. 5 years and above, 5 milligrams. Preferably have the nebulizer that is driven by oxygen, because if your patient is hypoxic and you are going to nebulize them there for 15 to 20 minutes, if you are especially using the old model nebulizers, then you are likely to end up with hypoxia, likely to end up with more trouble than you started off with. So that's something to think about. I know there are smart nebulizers which can do it faster if you are not using that oxygen. But you have to think of that protective, that hypoxia that can occur. Ipratropium bromide should be added 125 per each 2.5 milligrams. So if you are nebulizing this less than 5 years, just want to use 125 micrograms. In the initial phase, you can use it more frequently, but most guidelines discouraging use ipratropium bromide for more than 36 hours. Generally, the first 1 day would be more useful. Subsequently, you probably do not need to use that. In the earlier GINA guidelines, the oxygen saturation has been put, maintain it between 94 and 98. In the current guideline, they have just decided to say maintain oxygen saturation more than 94%. This is something I probably need to emphasize. I know because most of us, we manage from neonates to to the older children and even adults. When the preterm babies, we don't want them to saturate higher than 95 on oxygen, because we are likely to cause more of the retinopathy or prematurity. But that should not confuse in terms of this child who is having asthma. But when you are, maybe the patient is already stable and they have bronchiolitis, there are other considerations, including lower levels of oxygen levels. Antibiotics are not indicated in asthma unless co-infection exists or you feel, there's enough evidence that you cannot rule out your pneumonia or something at that particular point, especially fevers and other things. This again is from our national guideline and just tries to emphasize: one, patients who have life-threatening asthma exacerbation should be taken care of in the critical units, oxygen being there. And this is the place where we kind of differ with the adult medicine. That is actually, in ICU, you can still use the IV aminophylline. This is not in any adult guidelines currently. But again, remember, we have said in ICU. I know people used to use that long time ago, and sometimes you push, and by the time you finish, the patient has also gone. But the other thing that has now been emphasized is IV magnesium use. And previously there was the allowance that could be given as nebulizer, but the current GINA guideline now has removed that completely and only allowed that IV magnesium could be used in patients who have severe exacerbation. So sometimes things can be big or small, or they can have trees that are drying up and they're actually in water. So in summary, remember, diagnosis of asthma, especially for those below 5 years, may be difficult to ascertain. And this is where we are not saying that it's not that the diagnosis can't occur, it occurs, but the evaluation needs to be thought through appropriately so that we are able to put the right patients to the right category. Stable asthma classification needs to be thought of as the pre-starting the inhalers and that post-starting treatment. Remember to take care of the child's perception of fears, especially stigma that surrounds asthma. And this is a real thing in our setup. And finally, acute asthma exacerbation should be treated as soon as it is recognized. I wish to acknowledge my pediatric respiratory mentors, several of them, my collaborators, affiliated institutions, including those that are listed or shown in this diagram. Thank you, and I want to take it back to Dr. Stephen for the next session. Thank you, Doctor. Thank you, everyone, for
So
listening.
thank you very much, Dr. Justa Simba, for taking us through that insightful and informative CME on management of asthma in children. The next session is for Q&A. I can see there are already people who have put their questions on the Q&A section. Others have typed them on the chats. So allow me to start with Amir Mumin. Amir Mumin that's asked, with widespread stigma of inhaler use, is there any long-term side effects of recurrent inhaled corticosteroids, inhaler use, and salbutamol use? And then I'll take two sets of questions. Allow the Dr. Simba to answer, then proceed with the next set of questions. The other attendee has asked, kindly touch on cough variant asthma. Yes, Dr. Simba.
So sorry, I was still muted. So thank you for that, Doctor. Um, the issue about asthma and inhalers and stigma, I think it's more with the healthcare workers than the patients, and I have data to prove that. The work we did, earlier quoted, had quite a number of healthcare workers who are involved as parents of those children, and we were able to tease out that for sure. Um, uh, for sure, there is the stigma is driven by healthcare workers. Our patients who that statement of, oh, when you use this inhalers, they are going to affect you. Let's practically just do it very quickly. So um, a dose of prednisolone, and I had shown there, is 1 to 2 milligrams per kg. So just pick a child who is 20 kgs. They need to be on 20 milligrams once a day for 3 to 5 days. Commonly just use the lower, which is 60 milligrams. So one puff, if you are using budesonide, which is commonly available, it will give you, if you are using budesonide 200, it will give you 200. For example, you are doing 2 puffs, and that comes to around 400. For ease of math, me just make it that you're using 1 puff, which is 200 micrograms. Remember, you're having 20 milligrams a day. Now, this is 20,000 micrograms a day compared to 200. If you just divide that, you notice you require so many days to using the inhaled corticosteroid for that steroid. Because if this child for sure has asthma, you will most likely have ended up prescribing them prednisolone if they are sick, they are being sick enough. And so at the end of the day, just imagine 5 courses of steroids on an adult associated with decreased bone density. how much more will you have done to that child if you are going to be so afraid of the inhalers that you have to keep prescribing the oral steroids? So that's how to look at it. There are steroids, there is a bit of steroid in there. People have tried to compare the heights and heights, whether they really decrease, and eventually it has been noted that they actually not much difference in terms of height velocity that they acquire. And actually, you are more likely to end up with a less height for uncontrolled asthma child. They're likely to be small. Actually, remind me, the next question you picked was
To kindly touch on cough variant asthma.
yeah. So there are people who generally will, I mean, they have almost features of asthma, only that they will probably cough at night, cough when they run, but nobody has documented a wheeze on that particular patient. And so those patients still have asthma, just that you are less likely to find, for example, in spirometry, any features of obstructive most of the time. And those are patients who a good number of them will still do well on the inhalers. And subsequently, I think even the current Gina guideline mentioned that they are also likely eventually to have wheeze come on board. So it's true, there is that concept of covariant asthma.
Okay. If a patient is already on inhaled corticosteroids, stroke, and a combination of inhaled corticosteroids and short-acting beta agonist, namely Irovent, do we now switch them to ICS stroke LABA? And bearing in mind that the patient has been on ICS and short-acting beta agonists for many years and is partially controlled.
So thanks for that. So the last part actually solves the question that this patient is not controlled. So remember, using the step one, which I showed, is you can use innate corticosteroid together with short-acting beta agonist whenever it is required. And so this could be in separate canisters, or they could be in one canister as has been named in one of the drugs. So if this patient, that treatment is not working, so they're actually not supposed to be taken care of as if they're in step one, then you need to move to the appropriate step, which is likely to either be step two, step three. If, for example, this is an adult, remember I said ICS sub in a combination is actually not supposed to be used in children less than 12 years, has not been approved for that use generally. So then that particular patient needs to be put on the more appropriate ICS lab for them to be controlled. So I just talking to them, trying to have them really get to know that what needs to be done, and that it is possible that at one point they might go back to that particular medication, especially if they become controlled.
Thank you. Allow me to take three sets of questions which are interrelated. Number one is, must patient have wheezing to be diagnosed with asthma? Number two, how early can we diagnose asthma at what age? And number three, kindly comment on how to differentiate between asthma and chronic bronchiolitis.
Okay, thank you for those questions. So the first one is that patients, so wheezing, so the commonest symptom in asthma is actually cough. However, if a patient continuously has cough and whenever they are assessed, they never have wheezing, then we have to think of possibility of other diagnosis. While at that particular point, they will probably be diagnosed to have the cough variant asthma, which I've already mentioned. Then if they continuously, even when they appear to be very sick, for example, they come in acute exacerbation and there is no wheezing every time, then less likely that they actually have asthma. In terms of when to diagnose asthma, the short answer to that is can be diagnosed in any age, only that first, children below 2 years, the differentials are much more. It is worse for children who are below 1 year. So those children, ideally, proper consultation and referrals are required. Otherwise, you could just hook up that patient to inhalers, and they actually do not require and they actually do not require that kind of treatment, because one of the common things that makes children wheeze, especially in the infancy, could be reflux, could be food allergies, among many other things. So can be diagnosed any age, but our guidelines and most guidelines, our national guidelines, for example, say children below 2 years, you need appropriate referrals to specialists to try and see whether depending on your setup, it could be you need to refer to the pediatrician, it could be that you need to refer the pediatric pulmonologist, depending on the setup in which you are, but it can be in any age group. In terms of bronchiolitis, so remember, when you start saying chronic, so let's just get this. Some of the viruses I already mentioned, RSV, adenovirus, they can actually give you some bit of a bronchiolitis that tends to linger around for several months, 4 months or even slightly more. But if you keep having recurrence, then you have to, especially if you are going to say recurrence and this child is 3 years and you tell it, oh, this is just bronchiolitis you are having, then there we are probably not entirely right. But in the younger child, a child who had a bout of an infection, let's say in February, and they still appear to be okay, but once in a while their wheezing is peaked, as that could still be that initial insult of the bronchiolitis, depending on what exactly was the particular organism that offended or that was implicated in that case.
Okay, thank you. Two sets of questions. How do you manage pregnant women who present with severe asthmatic attack? And another question is, kindly comment on management of status asthmaticus in children.
Okay, so definitely I will pick the second one, which is basically what I did present. So one of the things I've tried to tell myself is that yes, I have the general principles. I know what probably needs to be done, but I wouldn't engage myself treating adult ladies who are expectant have acute exacerbation, because sometimes some of those things, the principle might be the same, but some of the things will change. So usually I will not myself go into that, but basically the principles are that they will require bronchodilators, they will require the oxygen depending on the level, they will require, if possible, they might require antibiotics, but I usually don't want to give expert opinion on that realm, which might be outside my tenants. In terms of that acute asthma exacerbation, is basically, just to recap, because I've mentioned basically that is, you have this ABC, which airway breathing short history that is forecast, and then physical exam that focuses to evaluate the severity of that asthma, and then your bronchodilator, the short-acting beta agonist, depending on the level. If they are too sick, you probably go to nebulize. If not, then your inhalers can still help you, and then the possibility of combining with the ipratropium bromide in those children who are a bit sick. From moderate and above, a steroid needs to be on board. So that's part of what I had mentioned earlier. So that's what you would do.
Okay.
I don't know whether Dr. Did you list Dr. Steven? Okay, we appear to maybe have lost him. I see the others were maybe maybe comments. I think the other person maybe was just giving information, and I think I had mentioned quite a bit of those things which have been provided in the webinar. I mean, on the chat. Um, uh, yeah, we have tried to answer the questions on the. Okay, maybe what should be. Okay, so maybe yeah, I will start answering a few of them as we get Dr. Steve back. Um, so I think someone has asked, can a child heal fully from asthma? So if you end up with asthma after 6 years, the patient, you could be controlled. You might have less flare-ups. You might stay for long without, but as long as the airways, as I demonstrated, have that feature of asthma in the right trigger, the patient might get back unexasperated. So karibu back, Daktari. I think we had lost you. I'm just trying to see whether there are questions that we could I think someone wanted us to comment on exercise-induced asthma. Uh, yes, exercise can trigger asthma, and there are people they will only get that because they have been to exercise. I think we have plans in some of the centers to ensure that we can actually test and confirm that this is what their issue is, while put you on some strenuous activity and try and test you on that. I think someone else had asked, please tell us examples of low dose and medium dose. So budesonide 100 micrograms, for example, in a child less than 5 years is considered low dose, and fluticasone, that would likely to be the 50, would be is the one which would be on the low dose. And then if you double that, then you are going to moderate and medium dose, and times that 3 will be higher than that. I don't know whether Steve, there's another you felt we should handle. Okay, someone I think is saying there are parents who would prefer to nebulize their children instead of using inhalers. Is there a role of doing long-term nebulization of both controller and reliever? Okay, if you while it is possible to nebulize to nebulize the steroids, you will notice that the guidelines allow that nebulization to be the eye passes to be used for a shorter duration. Otherwise, it's a bit of high dose. It's like giving that child 1 milligram of prednisolone every day, which if we are running away then from side effects of drugs, then we are right in their homestead by using that method. However, there are situations where, for example, children who might be having other neuro developmental issues, and they might not cooperate to be maybe given the spacers and the inhalers, there is a role. So that individualized care and looking at exactly what is it we are trying to answer. Is it we are running away from the inhaler? Is that the only thing? If that is the only thing, then nebulization will not be the key thing. So I'm waiting for you, Dr. Steven, now to guide me.
Okay, thank you. There are still a few questions. One, in an event of status asthmaticus, how much magnesium sulfate should be used?
Okay, so thanks for that. So the dosage, so they is usually given it should be I think up to 50 milligrams per kg if I'm remembering just the upper limit of it, and it's given as an infusion which needs to be given for some time. The reason why it's preferred that these patients are monitored is I'm sure those of you who are familiar with magnesium sulfate being used in labor ward, there are some things you need to check for that particular patient, and that's why in our guideline that particular drug was preferred that it can be used where there is a bit of monitoring can appropriately be done. Yeah, so I think
So the other question is kindly comment on the role of antihistamine in management of asthma and appropriately setting and the appropriate setting and age to prescribe it.
okay, so the issue about so first of all, antihistamine do not treat asthma. The shorter line of it is that one, but we already said a good number of patients who have asthma are would also be having allergic rhinitis. So there is a role for using that, especially for those patients who are having concurrent allergic rhinitis. And that therefore means that so antihistamine, for example, cetirizine is allowed to use from 6 months of age. Other antihistamines and I may not remember all of them. Others will be allowed from 1 year and such kind of thing. So if, for example, just stick to the cetirizine, which is more commonly available, 2.5 milligram, maybe in that 6 to 1 year, 5 milligrams to and can go all the way to 10 depending on the references. I know there's some institution where I fought with the pharmacist about 60 odd on 5 milligrams, but basically it's still, you can still use that 5 milligrams for that age, and then the older patients can now use the 10 milligram dosages. So I think for clarity, you should not have someone who has acute asthma exacerbation and then antihistamine are part of the concoction for things they need to take. That's not correctly handling what we have, but they have a role in patients who are having concomitant issues that antihistamines have been shown to have an effect.
Okay, thank you. I'm taking the last question from Dr. Shabir. Is there a role of nebulization with adrenaline or hypertonic saline in management of children with asthma?
So these two drugs here which have been put here, maybe I start with the one which currently I think is in the market. If I put it the way that you say you are now in the market, the one going fashion is the hypertonic saline. But the short answer is that for asthma, that doesn't have a role. It has a role in bronchiolitis, which is actually very debated, and maybe that can be a topic for another day. And if you check literature very keenly, you might notice it's actually approved for outpatient setup of patients who have bronchiolitis rather than the ones who are actually admitted. Adrenaline nebulization as adrenaline, not nebulization of adrenaline, not necessarily in asthma, but it's a nebulized drug that can be used in several things, including the bronchiolitis I just mentioned, including croup. And sometimes you get actually this patient who was having asthma, they are coughing so much. You have tried other things, and sometimes you end up just nebulizing them with that. Adrenaline is a drug. I mentioned somewhere there you need to ask yourself, does the patient have anaphylaxis? And so that it will come there as a subacute drug for those who are having anaphylaxis. So it still has a role somewhere, but it's specific roles, not as a general drug that can be used in each and everything.
Okay, thank you very much, Dr. Justus Simba. Once again, Dr. Justus Simba is a consultant pediatrician stroke respiratory specialist with MBCHB, MEd PITS, and a PhD and a lecturer and a senior lecturer at the Jomo Kenyatta University of Agriculture and Technology, and the author of the pediatric Victoria Pediatric Casebook. So we have come to the end of the first session. The next session, I'm going to invite one of the pharmaceutical companies. We only have one pharmaceutical companies who would like to tell us about their products and what they are offering. So we have Isaac. Isaac, if you're there, you can unmute your microphone and take us through your products for the next 10 minutes.
Yes, hello guys.
Yes, we can hear you.
Can you all hear me?
Yes, we can hear you, Isaac.
Yes, my name is Isaac Kiluta from Krishna, Krishna Chemist. I'm the one who's marketing this product called Montero Kid. Yes, Montero Kid is a combination of Montelukast and Lupatadine, 5 mg, is an antihistamine. It's a dual-acting novel antihistaminic with a potent H1 receptor antagonist, and also inhibits the PAF, that's the platelet activating factor pathway, which is also responsible for causing blood vessels. So in the case of, which results in the case of blockage of the airways, this in turn causes asthma. So as Dr. Simba just mentioned, that antihistamines are not used to treat asthma, but are used for cases of allergic rhinitis. Thus, Montero has been a relatively better choice in a seasonal allergic rhinitis compared to combinations such as the levocetirizine and montelukast since of the rupatadine. It's finding a better efficacy and also a safer profile. The rupatadine works more faster compared to other combinations and also for a longer duration of time, since when it's broken down, it also produces this loratadine, which also kind of have antistamic effects. So the patient can be able to have the antistamic effect for a longer duration of time due to the metabolites, and also as effective the rupatadine itself. So for the case of Montero kids, it's available everywhere along Thika Road and even around the whole region of Kenya. Anywhere you guys are, it's available. It's quite friendly, and we also have the Montero adults. We have the adult Montero and the adult kid. So that's basically what I have for antihistamine in asthma control. The other product that I'm also marketing is Oralex. Oralex mouthwash. It's a combination of chlorhexidine and benzendamine. The chlorhexidine is an antiseptic property, and the benzendamine is the analgesic property that helps deal with pain for patients who have mouth ulcers, meningitis, mouth sores, such kind of conditions. This is also available in gargle, that's the 200 ml bottle, and also in spray formulation, that's 30 ml bottle that has a nozzle for the spray. So basically, that's what I have: Montero adult, Montero kid, and also Oralex and Oralex spray. Thank you, guys.
Okay, thank you very much, Isaac, and thank you everyone for finding time to joining this online CME. We really appreciate your presence here and your availability for today's CME. Once again, my name is Dr. Steven. The CPD points will be shared through the emails that you used for registration, and also a recording of this webinar will also be shared. Thank you very much. We have come to the end of the CME. For those whose questions have not been answered, they will be addressed before the recording is shared. Thank you, and feel free to exit the webinar at your own pleasure.